Talking About Tumors with Ryan and Ryan. I'm Ryan Holstead.
And I'm Ryan Clin.
And today, for our 6th episode, we're going to be talking about metastatic gastroesophageal cancer and the current landscape of systemic therapy.
Hopefully the audio is a little bit better. We had some difficulties with the last episode, but thank you for bearing with us. Although it is a beautiful day here in New York City and a lot of people are outside, so hopefully we don't have too many audio issues.
So today we're going to be talking about the metastatic setting for both gastric and esophageal cancer. Although there's general differences in the approach to these diseases in the localized setting, whether that's neoadjuvant chemoradiation in esophageal, perioperative chemotherapy in gastric, or sort of a expert consensus for what to do with the GEJ junction, we tend to approach these diseases as being similar in the metastatic setting. In the United States and Canada and Western Europe, adenocarcinoma is the primary disease site, and that is where we'll be aware of most of our discussion revolving around today. There are still metastatic squamous carcinoma, and there are some subtle differences to the chemotherapy and evidence behind that.
Now, even though we made a lot of headway and a lot of improvements in the past few years, these diseases still remain very difficult to treat, and the outcomes are still pretty poor, with a 5-year overall survival of about 20%. So that being said, it's very important to get the supportive services on board as soon as possible. So things like referrals for palliative care for pain control, nutrition. There have been studies such as we've seen in lung cancer where early referral and early involvement of these services can actually improve not only patients' comfort but actually overall survival of the patients. So very important to get these services on board as soon as you can.
Just like with the localized setting, malnutrition can become a huge issue here, and many patients will have a rapidly progressive disease presentation, sometimes getting ill too quickly to even be able to initiate systemic therapy. I think it's also important to note that all the issues that happen with localized disease can also happen in metastatic setting, as most patients will present when they're already metastatic rather than as a recurrence after localized therapy. Because these initial symptoms may be bleeding or obstruction, such as esophageal obstruction or gastric outlet obstruction, dealing with the localized symptoms may have to take precedent over initiating systemic therapy. Although things like surgery and radiation are often very helpful in the localized setting, these may not be the ideal approach once the disease is already metastatic, as they will delay the initiation of systemic therapy. And if we're trying to get chemotherapy started in the range of weeks, we want a treatment that can relieve the obstruction quickly so that chemotherapy can be started without further difficulty. And often things like esophageal stents may be more effective than waiting for radiation to take effect.
There are some differences in the use of biomarkers and immunotherapy for the two different diseases, but for the most part, the cytotoxic chemo is pretty similar. So whenever you have a patient with newly diagnosed metastatic gastric or esophageal cancer, there are a few biomarkers that you want to make sure that you're checking before you start treatment, because this will impact even your first-line treatment. So you want to make sure that you're checking the HER2 status, PD-L1 status, the microsatellite instability status, whether or not it's MSI high, or some people call this deficient mismatch repair. Some centers also do send broad next-generation sequencing, if that's available. That can also be helpful, but the main ones that we're looking at are HER2, PD-L1, and MSI status.
And these are relatively new in the field, really only used within the last 10 years. So I also mentioned when we're doing the initial workup, it's not always clear where the primary tumor is, and a lot of times you'll see one of these cancers of unknown primary presentations where you'll see multiple abdominal lesions, liver lesions, but no dominant primary mass, which is partially because the CT scan is not well at identifying gastric tumors if the primary mass is not extremely large. So whenever you have a unknown primary, part of the workup for an adenocarcinoma would be doing an EGD and colonoscopy to try to sort out where the primary was. Often the histopathology will show a CK7 positive and CK20 variable for these upper GI malignancies, which is a bit less specific than the CK7 negative, CK20 positive, which was what we saw in colon cancer. So moving through the early 2000s, there was multiple iterations of systemic therapy that were investigated, and these are not unlike in the colon cancer setting, which was primarily a 5-FU driven treatments initially, that were then moved into doublet agents, eventually actually a triplet agent, and for up until the mid-2000 aughts. What do you call that when it's
mid-2000s?
Yeah, like the 2003, 4, 5, 6.
Yeah, mid-2000s.
That was the aughts.
Huh?
And moving into the mid-2000s, a triplet regimen had actually emerged as being the preferred treatment, and this was using an anthracycline such as epirubicin, cisplatin, and 5-FU. This therapy was considered preferred after a meta-analysis published in 2005 looked at multiple comparisons of different chemotherapy regimens. And this study, which was published by Wagner et al. In the JCO, it gives a nice kind of breakdown to the state of chemotherapy at the time. And they looked initially at chemotherapy versus best supportive care and found that improvement on overall survival compared to best supportive care. The estimates of the 3 trials analyzed gave about a 6-month overall survival benefit, although there were some flaws acknowledged by the authors there, and modern estimates over best supportive care give a more modest improvement. This study also looked at the differences of doublets versus single-agent chemotherapy, and they also found approximately about a 1-month overall survival benefit at the expense of some increased toxicity. The study also looked at triplet therapies, such as the triplet I just mentioned, and they also found a higher overall survival, but at the expense of higher toxicity. And the conclusions of this trial were that a triplet in fit patients would be the best option to proceed with. We're going to go into a lot of detail on anthracyclines when we move into the breast cancer literature, so we'll defer the discussion of that until our next series of discussions. But this is the first time we're talking about cisplatin, which is a platinum agent like oxaliplatin. It's probably worth going into a little detail on that now.
Yeah, so cisplatin is used in multiple different cancers, and for a detailed discussion of cisplatin, I definitely recommend listening to the Oncol podcast. They have a very good episode where they go through the history and the toxicities of cisplatin. Just to review briefly, some of the main toxicities that we worry about. Renal toxicity is extremely important and something that these patients need a lot of IV fluids before and after the cisplatin. So something you want to keep in mind, especially if you have patients with heart failure or pre-existing renal disease or recurrent ascites and tendency to accumulate fluid. That can be an issue with giving cisplatin to these patients. Other things are ototoxicity. So if you have patients that already have some hearing loss, you want to make sure that you're having audiology see them and monitoring their hearing function during treatment. Nausea, vomiting. Unlike oxaliplatin, which has a little bit less nausea, vomiting, cisplatin is very emetogenic, so you want to make sure that you're giving these patients good nausea meds to go home with after chemo and that they have good pre-meds before chemo. Other things that are seen with many of the platinum agents are neuropathy, and then of course, like most chemotherapies that we use, cytopenias.
In addition, the ECF regimen uses an interesting schedule with the 5-FU, which is daily 5-FU infusion. So for the entirety of the treatment on ECF, someone has a pump continually infusing 5-FU. It's not 48 hours, not 5 days, but 28 days in a row, which understandably can become burdensome and also has additional issues such as PICC line infections and thrombosis if you're continuously running chemotherapy through a line. These issues led to the REAL-2 trial. This is a trial that was a 2x2 design, so it was making 2 comparisons in a non-inferiority setting. Specifically the question of, are other triplet regimens as good as the ECF? And the 2 questions were, can oxaliplatin be substituted for cisplatin? And can capecitabine, an oral regimen, be substituted with 5-FU? And the bottom line here is that non-inferiority was shown with both comparisons. There were similar overall survival for all patients, which was a median approximately around the range of 10 months.
So looking at the toxicities on this trial, the capecitabine versus 5-FU had very similar toxicities. There was a difference between the cisplatin and the oxaliplatin groups. As we expected, the cisplatin group had higher grade 3 to 4 neutropenia, had more renal toxicity, had some more alopecia, with the oxaliplatin group having greater incidence of diarrhea and neuropathy.
Now, as we had gone into on our colon cancer episodes, there is an improvement using modern 5-FU doublets over the older regimens that used to be used, namely our FOLFIRI and FOLFOX. And at least one trial published in the JCO in 2014 did find that using FOLFIRI was equivalent to using ECX. More recently, in 2016, an updated meta-analysis, which was actually a network meta-analysis, was published. And this compared 17 regimens, doing 37 direct comparisons, and very complicated statistics that are a bit beyond me. And I've spoken to people who say that this is a legitimate study, but a very complicated to run, and try to look at all the different doublet and triplet regimens and try to individually compare to see which ones are most efficacious. Kind of the upshot of the study, and I recommend you take a look at all the different individual hazard ratios comparing individual agents, is that modern 5FU doublets were almost as efficacious as the triplets, but much less toxic. And I think the modern approach for most providers in looking at backbones used in clinical trials is to use a doublet using 5FU and some platinum-based agent or taxane-based agent rather than using one of these more toxic triplet agents, including anthracycline. In North America and in Canada, at least from my experience, primarily we're using either FOLFOX or FOLFIRI.
Yeah, exactly. That's what I've seen too.
One other extra caveat I'll just add on to there is this study, this network and meta-analysis was only looking at adenocarcinoma. So I think there still is an open question about squamous, and the bulk of the data historically were using treatments with 5FU and cisplatin in these patients.
So similar to many other cancers where immunotherapy is now playing a larger role, the same thing is happening in gastric and esophageal cancer, where we're trying to see who benefits from immunotherapy and what biomarkers we can use to predict who will benefit. So in terms of immunotherapy, we usually measure PD-L1, and this can be measured in two ways. I think we briefly mentioned this in the last episode. In lung cancer, we typically use the TPS score, which is the tumor positive score. And this is looking at the percent of only the tumor cells that express PD-L1. It's been shown that in gastric cancer, the CPS, which is a combined positive score, which looks not only at the tumor cells but also at the lymphocytes and macrophages, this can be a more reliable indicator as to who will respond to immunotherapy. So in gastric cancer, we're usually looking at the CPS score for PD-L1 rather than the TPS. Although, as we also mentioned in the last episode, some of the trials when they started, were using the TPS, and it was only either after they were done or midway through that they switched to the CPS. So it can make it a little bit difficult to interpret the trials in terms of how they're scoring the immunotherapy. So similar to our discussion in colon cancer, we also want to look at the MSI status for these patients, which is microsatellite instability.
Getting into the major trials that have led to immunotherapy becoming standard of care for our first-line therapy, I just want to first say that there's been a number of trials previously looking at trying to incorporate EGFR agents and VEGF agents, such as we've seen in colon cancer, that have all been unsuccessful. And although the added benefit of immunotherapy will sound somewhat marginal, this is the first time any added drug has improved overall survival to this extent in this specific disease site. And because of this, there's been a lot of interest in trying to find the best way to use immunotherapy in the setting. In general, for both esophageal and gastric, there's trials that have used either pembrolizumab or nivolumab combined with a chemotherapy. To the best of my knowledge, there aren't any major positive trials using the other immunotherapy agents at this time. So starting in the esophageal setting, a landmark trial was looking at chemotherapy with 5FU and cisplatin in esophageal squamous cell carcinoma, plus or minus pembrolizumab. This is a superiority trial with the primary endpoint being overall survival, looking at patients with a CPS greater than 10. This also had a secondary primary endpoint of looking at overall survival in all comers with squamous adenocarcinoma. And the trial did include some patients with esophageal adenocarcinoma and had a third primary endpoint looking at all comers, irrespective of pathology, or irrespective of histology or CPS score. This was a positive trial and did show that patients with a squamous cell carcinoma and a CPS score greater than 10 had an increased overall survival of 14 months versus 8.8 months, which was statistically significant. In the all-comer arena for squamous cell carcinomas, there was also an overall survival improvement of about 12.5 months versus 10 months, noting that the margin of benefit is smaller in this group. And in all patients, there was also noted an overall survival benefit of 12.4 months versus 9.8 months.
So largely based on the results of this study, pembrolizumab was approved regardless of CPS score for the upfront treatment of esophageal or gastric adeno or squamous cell carcinoma. However, given that most of the benefit was derived in patients with a CPS greater than or equal to 10, some people definitely do disagree and think that the use of immunotherapy in addition to chemotherapy should be reserved for patients with a CPS greater than 10. Because again, the benefit was really only seen in patients with CPS greater than 10, and it was also really driven by the patients with squamous cell carcinoma, who were the majority of patients in this trial. About 3/4 were squamous. And
this is going to be a common thing that comes up in a lot of the immune therapy trials, where there'll almost be this hierarchical group where we look at the patients who are most likely to benefit, then we lump in another group of patients, and we group in another group of patients. So the CPS greater than 10 squamous cell carcinoma patients were a proportion of the patients in the all-comer squamous cell carcinoma patients, and are also were a proportion of the all-comer overall, regardless of histology. And we see that the overall survival benefit gets a little bit narrower and a little bit narrower, and it's possible that we're seeing primarily weighting from the high CPS and squamous. And in the pembrolizumab trial, at least, they did look at the outcome of patients with CPS less than 10 in all comers, and this had a overall survival being relatively the same of 10.5 months versus 10.6 months. In the esophageal area, there's also a very similar trial run with nivolumab with similar outcomes, showing that the addition of nivolumab to a chemotherapy backbone did improve overall survival on the order of 3 to 4 months.
So moving over to adenocarcinomas, there was a study looking just at gastroesophageal and GE junction adenocarcinomas, looking at the addition of nivolumab to the chemotherapy backbone of 5-FU oxaliplatin, so either FOLFOX or CAPOX. This study also had an arm that was just nivolumab and ipilimumab, so chemo-free, just immunotherapy arm, as well as an arm that was just the chemotherapy alone. So the study did also show an improved overall survival with the addition of nivolumab to chemotherapy, 14.4 months versus 11.1 months. But the benefit was really only seen in patients with a CPS greater than or equal to 5, which was about 60% of the patients on the study. They found that if the CPS was less than 5, there was really no benefit to the addition of the immunotherapy.
The study used a hierarchical statistical test. So once the overall survival is shown in patients with a CPS greater than 5, they then statistically tested for overall survival in those with a CPS greater than 1. And when it was with the greater than 1, there was a numerically increased overall survival of 14 versus 11.3 months. But with hierarchical testing, you need a higher level of statistical benefit in order for this to make significance. And I think the same issues that we mentioned above, which is the CPS greater than 1 includes the patients with CPS greater than 5. We're really just seeing the benefit from those with the higher level.
So in the study, even though there was improved overall survival with patients with a CPS greater than or equal to 5, an unplanned subgroup analysis actually showed that most of this benefit was actually probably driven by patients with a CPS greater than 10. Because when they looked at patients with CPS less than 10, there seemed to be no benefit to the addition of nivolumab with a overall survival of 12.4 months versus 12.5 months.
And the follow-up publication looked at the comparison to ipilimumab and nivolumab, the chemo-free arm, and did not find that these had any benefit. Just briefly before we go into the next of the immunotherapy trials, I just wanted to talk about the concept of alpha spending, because a lot of these clinical trials, as I mentioned, have multiple primary endpoints. So like the one we just discussed, the primary endpoints we're looking at overall survival or progression-free survival in patients with a CPS greater than 5. Remember with our clinical trials, we're usually aiming to get a P of less than 0.05. So when we are looking at multiple things, each individual thing cannot have a P of less than 0.05, because then if you're looking at both of these things with a P of less than 0.05, the total chance that one of these outcomes could be due to chance would actually be a higher percent likelihood. So we have a concept of alpha spending where we allocate some of our P, or statistical chance, to one of the outcomes, such as overall survival, and then the other component to progression-free survival. This is will be seen in a number of trials that we'll discuss later on, where maybe the trials will weight and say 0.04 will be weighted towards the PFS arm, which usually is more likely to be positive, and then 0.01 will be weighted to the overall survival arm, which will sometimes make that the overall survival is unable to show statistical significance despite having a numerically superior outcome. These are complex topics that are good to be aware of and look into literature written on this, and we don't really have the time to kind of delve too deeply into this, and there's much better statisticians who have explained this in greater detail. But when reading a trial, it's good to know how outcomes were planned for, so that when we see the final conclusions, we can interpret the results. In a similar manner, it's important to know that the more things we look at, the more likelihood that spurious findings might be due to chance. That's why you'll not often see any p-values attached to subgroup analyses when you see those large forest plots, because these are so many individual comparisons that you cannot allocate any of your alpha to those individual analyses.
The last immunotherapy trial that we're going to talk about today is the KEYNOTE-062 trial, which is looking at pembro monotherapy, so pembrolizumab without any chemotherapy versus chemotherapy versus the addition of chemotherapy with pembrolizumab. And this was in patients with adenocarcinoma, either gastric or EGJ, and it showed that the pembrolizumab monotherapy arm was actually non-inferior to the chemotherapy arm in terms of overall survival. However, there was a lower overall response rate, so the chemotherapy arm had a response rate of 37%, and the pembrolizumab arm had a response rate of 15%.
And this was even a more complicated trial because it had 6 hypotheses. Some were superiority, some were non-inferiority. And although they did find an overall survival benefit in those patients with a CPS greater than 10, measured at 17.4 months versus 10.8 months, they could not even do statistical testing on this because one of the prior hypotheses that needed to be met was not met. So although this is the one trial that indicates a potential role for pembro monotherapy in those high CPS patients, I think the bulk of the evidence points towards using a chemo and immunotherapy combination for most patients, and with the best benefit in those with a CPS at least greater than 5, and more likely those with greater than 10.
I think this might just make you more comfortable if someone's really not a candidate for chemotherapy, but they would be willing to take immunotherapy. If someone has a CPS greater than 10, maybe you feel a little bit more comfortable if they don't have bulky disease, because again, their response rate was not as good. If you don't need a quick response, maybe you feel a little bit more comfortable doing just pembrolizumab.
Yeah. FOLFOX is pretty tolerable for the most part, but I guess if someone's really frail.
So coming back to the MSI status, there have been, unlike the trials that we just spoke about, there haven't really been any prospective randomized trials looking at patients with MSI high or deficient mismatch repair. However, when you look at subgroups of these studies, such as the KEYNOTE-062 or the CheckMate 649, the ones where we were combining chemo and immunotherapy, when you look at the subgroup of patients that are MSI high, they definitely show benefit regardless of the PD-L1 status.
There's also an umbrella trial where all patients with any MSI high tumors were administered immunotherapy, and this trial did include a number of gastric patients who seemed to have a good response. So the other major molecular target is HER2, and HER2 is a receptor, part of the EGFR, ERB family. We're going to be speaking about this in great depth in breast cancer, where it's been a major target. In gastric cancer, it's present in about 15% of the tumors, primarily those in the GEJ junction, right?
Yeah, more common in GEJ.
And not very common in esophageal, but anyone with a metastatic adenocarcinoma, it's worth testing for this because it does open up some additional treatment options.
Now, when we're testing for this, we need to make sure that the pathologist knows that we're testing for gastric cancer and not breast cancer, because although HER2 is used in both, the testing is actually different in breast versus gastric. Yeah. I'm not going to get into the subtle differences because I think it's more relevant probably for pathology, but there are...
The way that they measure it's a bit different. In both cases, you're going to get a score of either 0, 1+, 2+, or 3+. And in general, 3+ is considered positive, and then 2+, which is an immunohistochemistry marker, would be followed up with a confirmation with FISH, in situ hybridization. But what actually makes something 1+, 2+, or 3+ is different if it's a gastric tumor or a breast cancer tumor. more important for a pathology lecture than for a medical oncology lecture, but it is a conversation that comes up sometimes at tumor boards with these unknown primary cases.
So the first study that looked at this is called the TOGA trial, and this was looking at the addition of trastuzumab, which is an anti-HER2 agent, to chemotherapy. And this one used a chemotherapy backbone of cisplatin 5-FU. And it was a phase 3 trial with almost 600 patients, 594 patients. And this study included patients that were HER2 positive. However, they included patients that were HER2 IHC 1, 2, or 3 plus, as long as they were FISH positive. So a little bit different than what we do today, where again, HER2 positive is either 3 plus or 2 plus with a positive FISH. This study included anybody that had a positive FISH, a positive FISH, even if their IHC was only 0 or 1. So the primary endpoint of this study was overall survival, which was improved in the trastuzumab group, 13.8 months versus 11.1 months, with a hazard ratio of 0.74. And it also had an increased overall response rate of 47% versus 35%. Now, as we said, the patients that were included in this study that had FISH positive but were IHC 0 to 1, in this group, the trastuzumab was ineffective. The hazard ratio was greater than 1, it was 1.07. So there was no benefit to the addition of trastuzumab to the patients with IHC 0 or 1, even if the FISH was positive.
Yeah, and because of this outcome, that's why we approach it the way we do today.
Yeah, so it was most effective in patients that had an immunohistochemistry of 3 plus. Hazard ratio was 0.66. In patients with immunohistochemistry of 2 plus, the hazard ratio is 0.78. So positive, but not as, the overall survival benefit was not as significant. And looking at the toxicities, so we'll get more into the toxicities of trastuzumab again when we talk about breast cancer, where it's very widely used. There was an increase in diarrhea in the trastuzumab arm, as well as an asymptomatic decrease in left ventricular ejection fraction.
Yeah, the heart failure issue is a big one in adjuvant breast cancer because these patients receive anthracyclines, which, as we'll get into, can cause significant short-term and long-term cardiotoxicity. And then they're followed up shortly receiving trastuzumab. And patients did have clinically significant heart failure in the breast cancer trials. However, those in this case have not seemed to be so significant. One question is what is the best backbone? And the TOGA trial came at a time when cisplatin 5-FU was a favorite therapy. As mentioned, this is now mostly supplanted by either FOLFOX or FOLFIRI. And although there's no specific trials that have looked at FOLFOX combined with trastuzumab or FOLFIRI combined with trastuzumab, I think it's a reasonable approach to consider as from a drug efficacy standpoint. There's no reason why cisplatin 5-FU should be any better than FOLFOX when we're combining it with trastuzumab.
Yeah, there have been some meta-analyses that included really just small studies and some retrospective studies looking at the addition of trastuzumab with FOLFOX or KFOX versus the cisplatin 5-FU. And they seem similar, at least in the little data that we have. When speaking about HER2, then there's also the question of, does pertuzumab, in addition to trastuzumab, such as is used in breast cancer, so pertuzumab is another anti-HER2 agent, which is often combined with trastuzumab in breast cancer. There was some thought maybe this could be also useful in gastric cancer. However, in the studies that have looked at this, none of the studies so far have been positive, both with pertuzumab and many other HER2 agents. So right now, for first line, really trastuzumab is the go-to HER2 agent.
And all of these HER2 agents were also looked at in the second line, and really they were consistently negative time after time, until more recently, one of the novel HER2-directed drug conjugate antibodies, so combining chemotherapy with trastuzumab, a drug called trastuzumab deruxtecan, has been able to show some benefit in, I think it's the third line setting, right?
Yeah, third line setting, the Destiny Gastric 01 study.
And this was compared to single chemotherapy arms and found an increase in the overall response rate, which was the primary outcome, of 51 versus 14%. And although not statistically tested, the overall survival was numerically increased by 12 versus 8 months. And the study was primarily run in Eastern Asia and Japan, so I think and there's an ongoing study in the US to try to see if this reflects North American populations as well as in larger numbers, seeing if there's truly an overall survival benefit.
Yeah, there's a study looking at this drug versus one of the commonly used second-line treatments, which we'll speak about, paclitaxel and ramucirumab, to try to push this agent up into the second line for HER2-positive patients. But the results have not yet been published.
With these drug-antibody conjugates, often we're combining a very toxic chemotherapy with the hope that the antibody can direct that directly to the tumor to limit systemic toxicity. Although this is generally efficacious, there is still some significant toxicity with these drugs. And in the case of trastuzumab deruxtecan, you can see that rates of nausea and diarrhea, neutropenia and anemia, and a very significant and not altogether rare risk of interstitial lung disease, which in the DESTINY-01 trial was about 10% of patients. Due to this ILD, I don't expect this drug to move up into the first line, but it does seem to be a very effective option to have for those who've progressed after their initial trastuzumab-based therapy.
So more recently, there have been attempts to combine immunotherapy with anti-HER2 agents, and this was seen in the recently published KEYNOTE-811 trial, which is looking at the addition of pembrolizumab to trastuzumab and chemotherapy, either cisplatin 5-FU or CAPOX. And this was in patients regardless of the PD-L1 status. So the primary endpoint of this study was actually overall response rate, which did show that it was higher in the group that had chemotherapy, trastuzumab, and pembrolizumab versus the chemotherapy and trastuzumab arm. The overall response rate was 74% versus 52%. Kind of surprisingly, this was approved, so pembrolizumab can be used in the first line for patients with HER2-positive gastric or EGJ adenocarcinoma, regardless of the PD-L1 status. However, some people may want to see, overall survival or at least progression-free survival data before reaching to this, but it is available and approved. It should be noted that 87% of the patients in the study did have a CPS greater than or equal to 1. So even though they had let in kind of all comers, it could have been driven by these patients, the increased overall response rate.
So let's say you have a patient who's progressing on first-line therapy and they're HER2 negative. We do have a few options in that setting, and as Ryan alluded to earlier, ramucirumab and paclitaxel is probably our best data in the second-line setting for HER2 negative disease. This was a trial that followed up on the benefit of paclitaxel, including improving overall survival compared to placebo alone, and was looking at ramucirumab and paclitaxel versus paclitaxel. The schedule for these drugs are paclitaxel is given on day 1, day 8, and day 15, so 3 weeks in a row, then a week off, and ramucirumab is given every 2 weeks. This study was a positive trial. It did improve overall survival by about 2 months, so from 9.6 months versus 7.4 months. And the combination arm had about a 30% objective response rate versus 15% with paclitaxel alone. A 30% objective response rate in second-line setting for an aggressive disease such as this is actually quite a good outcome. I don't think we've talked about taxanes yet, but we'll be talking about them in great detail with breast, so this will be another chemotherapy that I'll defer for now. Worth mentioning, the toxicities shown in this trial were neutropenia, hypertension, and other VEGF toxicities such as thrombosis and bleeding. So
seen in colon cancer, LONSURF, which is trifluridine and tipiracil, has also been studied in the third-line setting for metastatic gastric adenocarcinoma only, not squamous. And this study did show an improved overall survival of 5.7 months versus 3.6 months. So similar to colon cancer, it is a pretty modest benefit. However, the study used heavily pretreated patients. So if you have somebody who you really don't have any other options and they have a very good performance status and are still motivated to keep getting treatment, then this could also be an option as well.
And don't forget about FOLFIRI being a very effective treatment. So if you're first line, you're using FOLFOX, keep FOLFIRI as your backup. And if you prefer to use FOLFIRI as your front line, then use FOLFOX as the second line. My suspicion is probably FOLFIRI is going to show up less and less in the first line setting, just given that most of these immune therapy trials have incorporated a platinum agent as part of the regimen. The bottom line here is that there's been a lot of new therapy regimens coming out really in just the last 3 or 4 years. Probably by the time we get a chance to actually revise this episode, And in 2 years, the treatment regimen will change. But for now, I think you have a patient come in with gastric cancer, you're going to send off their CPS status with the thresholds that you're going to care most about are going to be a CPS greater than 5 or a CPS greater than 10. You're going to look at the histology to see whether or not it's adeno or squamous carcinoma. You're going to cross your fingers and hope that they might have a MSI high status or HER2 positive status, which, albeit rare, do open up a lot more treatment options. And you're going to keep in mind that you're going to need to incorporate your ancillary care services and address any symptoms when the patients first present to you. I'll run down the treatment options.
So for patients that are MSI high or deficient mismatch repair or a CPS greater than 5, well, some could say greater than 10, you would consider the addition of immunotherapy to your chemotherapy backbone. So either nivolumab or pembrolizumab. The patient's really not a chemo candidate, then you can consider pembrolizumab monotherapy for someone who doesn't have very bulky disease and has a CPS greater than 10. So for patients that are HER2 positive, we would consider the TOGA regimen, which is trastuzumab in addition to chemotherapy, so either cisplatin 5-FU or FOLFOX or CAPOX. And given this new trial that just came out, the Keynote 811, some providers would consider the addition of pembrolizumab to trastuzumab and chemotherapy given the results of this study. However, you have to understand that the primary endpoint was just overall response rate, and we still have no progression-free survival or overall survival data. So it would be prudent to wait for this data to come out before recommending that to your patients.
Yeah, I'd have a hard time really recommending this one. And lastly, keep in mind to think about clinical trials. This is a changing field, and there's going to be many trials that are open. Most of them are going to be biomarker-driven in diseases such as this where our outcomes are still quite poor. We want to really be trying to find ways to improve the quality of care we can provide to our patients. So for the next few episodes, we're going to move through some also very difficult to treat tumors. We're going to talk about pancreatic cancer in the localized and metastatic setting, as well as cholangiocarcinoma in the localized and metastatic setting. After that, we'll move on to some... where are we going after that? Well, no. After that, we're going to take a break away from the GI and move into the breast tumors, which will be some good discussions there as well. As always, thanks so much for listening.
Yep, thanks for listening. And please let us know if you have any feedback, anything you love or hate about the podcast. We'd be happy to hear it.
Yeah, we're trying to keep improving this, and hopefully the audio is better, but we want the content to be good as well. So let us know if there's any concerns.
Thanks for listening. Take care. For more information, follow us on Twitter at Talking Tumors, or feel free to email us at talkingabouttumors@gmail.com.
Please rate and review the podcast. We really appreciate it.
And special shout out to our friend John Kim for all of his musical talents.
And he is the composer of the music that you're hearing right now. Talking About Tumors is not medical advice.
For medical advice, please contact your own healthcare provider.
Opinions stated on this podcast are by the Ryan who said it and no one else. We have no financial disclosures, and this is done purely on our own time to the sake of our enjoyment of the field of medical oncology. Thank you for listening, and see you next time.